all. This is Dr. Mobeen Syed from DrBeen.com. Welcome to one more show. So today we have, as you can see, a very special guest. We have Dr. Bruce Patterson with us from IncelDX. He is joining us maybe about 2 years
Hmm.
after. And during this time, he has been chasing the long COVID and the labs and the diagnostic criterias and what works and what doesn't work. So this is, I believe, a gift for everyone who is watching. So first of all, Dr. Bruce Patterson, welcome.
Thank you, Dr. Bean. It's a pleasure to be here again after so much time.
So tell me a little bit about what's happening in your world at this time. And for our audience, what are you up to? And then we'll talk about long
Yeah.
COVID.
I think we can divide what we've been up to in three categories. One was refining our algorithms with machine learning and AI to not only have a diagnostic for long COVID, which we do, but also be able to distinguish long COVID from other chronic inflammatory conditions like chronic Lyme, uh, chronic fatigue syndrome or ME/CFS, fibromyalgia, and even from acute COVID with the new surges that are coming out. And so that was what was critically important. And again, we've also spent a lot of time launching this test around the world. It's already commercialized. I keep hearing in the media that there's no diagnostic for long COVID or they're still focusing on symptoms. And it's just absolutely not the case. We've used this in over 10,000 patients. And as you can see in the algorithm, we've really refined using machine learning and AI the algorithm to the point where in our 14-plex cytokine panel, which is now reimbursed and reimbursed by Medicare, you can clearly delineate past or long COVID, which is the blue circle, non-perturbed, which is healthy controls, and acute COVID in yellow, and Lyme in green. And you can see that these pies are solid pies. There's no other slices of any other diagnostic or diagnosis in these pies. So not only can we detect long COVID and say who has long COVID and who doesn't have long COVID, most importantly, but we can say, are we dealing with Lyme or chronic Lyme, or are we dealing with acute COVID, which falls under non-perturbed? And the reason we have a non-perturbed category is when we use the long COVID signature, which we published over 2 years ago now, and created the long hauler index, acute COVID falls out. In other words, there's no overlap between acute COVID and long COVID, which is absolutely critical because we have the capabilities of detecting long COVID now in the middle of a surge. And I truly believe that COVID's going to be around for a long time. And so we need to be able to say who has long COVID in a population that's still experiencing acute COVID. And then the other thing I would say in the past 2 years through our chronic COVID treatment center, we've picked up maybe 200 to 300 patients who never knew they had the organisms that cause Lyme. And those are clearly distinguished through that algorithm that you just said or showed. And the bullet points, the cheat sheet, if you will, for somebody who has chronic Lyme is elevated interleukin 8 plus elevated interferon gamma, or elevated interferon gamma plus elevated interleukin 13, or a long hauler index greater than 6. All three of those conditions are highly, highly suggestive of Lyme, and we reflex to tick-borne disease screening tests at that point to determine what they may had. And Lyme diagnostics have come in a long way since the last decade, where it was basically a serologic diagnosis, and much like EBV and CMV and HSV, relying on serology and the fact that you were exposed was a very difficult interpretation. And so there's newer tests for Lyme which answer the question, is it active or not active? And I think that's been a huge advance in how we understand chronic inflammation. And we're
Absolutely.
working on some of those tests for the chronic herpes family viruses as well.
Absolutely. So thank you very much for this one. So one big, in my opinion, breakthrough is that you are able to differentiate between these conditions, and then you can focus on what to manage and how to manage it.
Right.
I wanted to give a disclaimer though at this time. So Dr. Bruce Patterson, of course, is coming from an organization. They have their commercial tests, as he mentioned. I wanted to make sure that everybody knows there is no money that has changed hands, and there is no money that ever had changed or exchanged hands. So this is purely an organization who has made breakthroughs in understanding long COVID. I'm sure that some part of that long vaccine as well. And then some protocols are present as well. And I would love that to be presented to you, our audience, and there is no other strings
Correct.
attached. Is that correct, Dr. Patterson?
Absolutely. It's we wear two hats after coming out of Stanford and being an academic for over 25 years, and all of a sudden running a company. There's two sides of your brain that are at work, and yes, indeed, we're running a company, but it has its advantages because when we talk about our diagnostics in our clinical trials for our drug combination, we've gotten these out to the market without taking any public funds. I've said this many times that, to use taxpayer money to pay for trials that may or may not work, and having people who are actually suffering pain for that is very difficult. And so
Absolutely.
we've funded it entirely privately, and we feel really good about that because I also think it's much faster to bring important discoveries to market through industry than in academia.
Absolutely. So thank you very much. I wanted to make sure that I provide this disclaimer. So now let's talk about long COVID. So you have a bunch of other slides as well. One thing that I want to do is I want to share with the community your and your team's previous and current work that is published. So I believe we have done a discussion about this one,
Yes,
immune-based predictions of COVID-19, correct?
that's correct. And that was the basis for the development of our diagnostic based on machine learning and AI and the differences between long COVID, mild to moderate acute COVID, severe acute COVID, and healthy controls. And again, we've gone from this paper to having the test fully commercialized and even CE-IVD marked in the EU.
Excellent. And here is another paper of yours and your team's that has been still circulating with a lot of um, trust and uh, reliability. This paper, the S1 protein in the monocytes.
That's correct. And truly, it was the finding of elevated non-classical monocytes, which was later corroborated by Iwasaki's group, and the fact that we actually even found S1 protein in those cells. We found fragments of RNA by whole genome sequencing, and found only 5% of the genome in these cells in terms of RNA. But the fact is, these cells, these non-classical monocytes, target blood vessels, and that's what led to our finding that long COVID, one of the major mechanisms is vascular inflammation. And in fact, paper just came out from the NIH today on the infection of endothelial cells with SARS-CoV-2 and formed the basis of the potential for that to happen in vivo, when in fact we had already shown in vivo that these endothelial cells are indeed inflamed. They cause platelet activation, production of SCD40L, RANTES, and VEGF. As a result, they become vasodilated and lead to symptoms such as headache, migraine, fatigue, brain fog, etc. And frankly, with dilated blood vessels, your ability to regulate temperature is off. So you have hot, cold insensitivity when you have long COVID. The POTS is really the dilatation of the blood vessels where they dilate, your blood pressure goes down, your heart rate goes up. As soon as you relieve the vascular inflammation, that all goes away. Not so there's
Very
really,
interesting.
you know, it's amazing how many symptoms go away. And that was in the paper that you'll show next, in our February paper, which
Oh, yeah.
although a small study, the key findings were that all 5 symptom scores decreased with statistical significance with Maraviroc and statins. The fatigue score decreased, dysautonomia score decreased, neuro score decreased, cardiac score decreased, and shortness of breath decreased. But then it was a yeoman's task by our statisticians who then went on to correlate specific symptom with specific inflammatory markers. And so we've gotten to the point where we've closed the circle on infection, inflammation, symptoms, treatment. And to my knowledge, is the first that's been done in long COVID, where you can actually say, if I bring these cytokines down, for instance, interleukin 2 and TNF alpha and fatigue, where the correlation coefficients are very strong, very low p-values, that we can predict that fatigue is on its way down. And that's what gives us great confidence going forward as we monitor patients and also think about what to look for in our randomized clinical trial.
So, just to recap, in the last years, you have not only figured out how to separate out Lyme from MECFS, from acute COVID, and from long COVID, you have actually commercialized a kit for that as well. You have figured out what is the protocol that can help,
Mm-hmm.
and you have done an AI-based system, and you have done the studies to show how endothelium gets damaged by these monocytes carrying S1. So that is a lot of good work. I want to ask you a question before we go to those presentations that you have, these slides. Sometimes patients reach out to me and they have been watching some videos, and then they talk about your organization and your tests and your protocols. And there are some folks who say it does not work for me at all. And then
Mm-hmm.
there are some that say, I cannot live without this protocol. This is what got me back on my feet. So what is your observation?
And I think it's really the nature of the progression in our knowledge of long COVID. And because in the beginning, and I think a lot of the patients early on are very vocal because they're now on year 3 of having long COVID. We didn't have the capacity to say, well, it's not long COVID, it's actually tick-borne disease, or it's MECFS, or it's fibromyalgia. We didn't have the algorithms to tell that like anybody else did. The other thing is a lot of people would take the drugs for a few weeks, not take them, then take them and not take them. And I think the key to success with any regimen is it's 6 to 12 weeks. We test every single month with non-subjective biomarkers that we now can correlate to symptoms, and also do symptom scores so that we know exactly where you are in the spectrum. And yes, we can add other drugs to a Maraviroc statin background. But most importantly, if we figure out that it's tick-borne disease and someone's never been treated, maybe we're doing doxycycline for Borrelia, for instance, plus Maraviroc and statins to take care of the immunologic aspects of chronic Lyme. Because at the end of the day, that's what's causing the symptoms. It's not the bug. And again, we now have preliminary data that in Lyme, Borrelia burgdorferi, as a matter of fact, can shed peptidoglycan or cell wall, just like S1 we're finding in blood in long COVID, and the peptidoglycan can be found in non-classical monocytes, which then bind to epithelium, endothelium, and then cause inflammation. So very, very similar mechanisms underlying the pathology, because the one common thing that we do see amongst those three conditions is vascular inflammation. However, back to your question, we can treat the vascular inflammation, but the symptoms may not be ameliorate, or the vascular inflammation may not go away completely unless we treat the underlying bug. So with chronic Lyme, maybe doxycycline or another regimen for Bartonella, or for Epstein-Barr or the chronic herpes family viruses, if they've reactivated, valcyclovir. So yes, we've evolved,
Mhm.
and I think the whole key to defining which patients respond, which patients don't respond, is correctly categorizing them. So across the board, I think that's going to be necessary as we explore different therapies for long COVID.
Got it. Thank you very much. And very quick comment to the audience. If you have any questions, I see some questions here. Please make sure that you have those QQQs. I just saw John's Qs over there. I want to go through just one more topic before we start answering some questions as well. And that is this slide. So, Dr. Patterson, the endotheliitis or vascular inflammation or swelling of the blood vessels, that is still, in your observation and your studies, the primary damaged tissue. Is this
Absolutely.
correct?
Yeah, absolutely. And I think, again, the NIH study today that came out on the potential of SARS-CoV-2 inducing direct inflammation in the endothelial cells just supports that as well. And again, you see here in green those non-classical monocytes binding to the endothelium through the fractalkine receptor and through the fractalkine protein on the endothelial cells. They then internalize and cause production of interferon gamma and interleukin 2. Well, guess what? That's the numerator of our long hauler index. So this paper was published in 2004. And when we did machine learning and AI on the cytokine profiles in long COVID, the computer picked out the long hauler index based on interleukin 2 and interferon gamma upregulation, which just happens to be the mechanism that was defined in the atherosclerosis literature in 2004. And I'll tell you why this is absolutely important. Number one, if there's this damage to endothelium, then there's platelet activation, production of SCD40L, which we detect in our panel, etc. And again, like I said, this elevated non-classical monocytes was corroborated by Iwasaki about a year later in a paper. So, this is a major underlying mechanism. And there's two pieces of evidence. Number one, we see the same thing in some patients following vaccine where they don't have virus. All they have is the S1 protein being produced by the RNA in the vaccines, and they have the exact same pathology. They retain S1 in non-classical monocytes, and they produce a long hauler index in the absence of ever being infected by COVID itself. So that corroborates this mechanism, and it corroborates the fact that you don't need replicating virus, which I haven't been able to find using whole genome sequencing. Really corroborates this as a major mechanism in both long COVID and long vax. And just a
That's a
comment on
sorry.
persistence, which we published 2 years ago. Persistence, in my mind, means there's persistent proteins, there's persistent RNAs. But when we did whole genome sequencing of both tissues in long COVID and in monocytes in long COVID, we found less than 5% of the genome. And as I say, you can't make a building with 5% of the bricks. And the fact is, you don't even need the virus; you just need the S1 protein to cause a similar pathology in long vax.
So I have two or three questions here. One, very quickly, just a comment here. I wanted to make sure that the audience can digest this diagram. So in this diagram, these red blocks are the endothelial cells. These are the inner surfaces of your blood vessels. These red tree-looking things are the fractalkenes, correct?
Correct.
And this green one is a monocyte. And that
Non-classical
monocyte,
monocyte. Mm-hmm.
non-classical monocyte, correct?
Yep.
And so this green one, non-classical monocyte, is running around in the blood vessels, and then it comes across these fractalkenes, it binds there. Then if you see here, it is causing a local inflammation and damage to the endothelium, which would then, as Dr. Bruce Patterson said, would set off local inflammation, causing platelet activation, thrombi and coagulation type, not coagulation, thrombi formation. And then the monocyte itself goes under the blood vessel, that means outside of the blood vessel, into the tissue, and starts going and creating inflammation there as well. So this is a disastrous situation, because not only the blood vessel itself is now swollen and inflamed, but the tissue surrounding it is also damaged, which is also going to cause further damage to the blood vessel. So I now have a few questions. Last time, 2 years ago, when we were talking about these mechanisms, one question that I had in my mind was, and we didn't have an answer at that time, how did monocyte end up with S1, and how do they keep living carrying that S1 with them?
Right.
Have you had any further breakthrough there?
Oh yeah, and I think it's a great question, and we thought a lot about it. I mean, bottom line is monocytes are phagocytic, and then they differentiate. So you start with a classical monocyte, and you get intermediate monocytes, and then non-classical monocytes, and they can differentiate, but they're capable of phagocytizing, dying off virally infected cells. And the one observation that I didn't discuss, I think the last time we were on, is that we also found S1 in intermediate and non-classical monocytes in severe acute COVID. So we think that may be predictive of who may get long COVID, in that these reservoirs are set up very, very early. Then when these cells are presenting antigen, it short circuits their apoptosis or death program. So they're long lived. So everyone used to say, oh, well, hey, Patterson, these cells only live for a week. Yes, normally, but these are not normal non-classical monocytes. They are expressing protein, and they're carrying protein. So their apoptotic pathway has been shut off, and they need to bind to the blood vessels. So using a statin, we downregulate fractalkine, and Maraviroc keeps these cells from circulating all over the body, including through the blood-brain barrier. So it's twofold. We keep them from migrating all over, and we keep them from binding to the blood vessels. If they can't bind to the blood vessels, they die. And so that's another question. How do you get rid of that S1, at least in these monocytes? And that's how they get rid of each other. And so, but the other thing that CCR5 antagonist Maraviroc does is it cross-links CCR5, which from the cancer literature shows that it reprograms or repolarizes macrophages away from a pro-inflammatory phenotype. In other words, the bad inflammatory proteins, interleukin 6, TNF alpha, VEGF, are made by monocytes macrophages. And CCR5 antagonism reprograms so they're no longer pro-inflammatory. And that's where we see decreases IL-6, decreases TNF alpha, CCL5, VEGF with Maraviroc. And that's why it's been such an amazing drug, because it's a very targeted drug in terms of turning off certain inflammatory protein production.
So I want to thank you very much for this explanation. It is just bringing so many images in my mind, and a quick story, just like you said, that people said, hey, monocytes die in 6 days, 7 days. Why are you saying they're there after a year? I want to tell you a story as well. One of our partner organizations working with DrBeen, they objected on one of the discussions that this paper that you have, the S1 with the monocytes, I presented that paper. They sent me a letter saying that we are seeing that you are presenting incorrect information. And then they had given the example of the incorrect information. and that was Dr. Mobeen has said that there is non-classical and there is classical monocytes. And my mind just blew. So I called them and I said, one, I have a reference paper. Number two, here are a ton of other references, because you are not discovering the non-classical and classical or intermediate monocytes. That is a discovery that has already happened. You are just looking at one of the monocytes to say, hey, this is carrying S1. So I sent them all of those links, and I called them, and they said, well, we had a board of doctors sit down. There were 6 people in that board. They looked at your claim that there are non-classical and classical monocytes, and we believe that you are wrong. And so they did some punishment to me for saying incorrect things. And since then till today, anytime I think about you and the S1 and the non-classical monocytes, I get remembered for that organization, which is actually one of the very large organization in the US for medical education providers. And they're thinking that there is no such thing as a non-classical monocyte. So thank you very much for being here and talking about that once more.
Well, if you read our persistence paper, we cite at least 3 articles that go completely through the monocyte subpopulations. And I can tell you right now, I don't know if they know anything about flow cytometry, hopefully as an immunology group, but classical monocytes are CD14 high, CD16 negative. Intermediate monocytes are CD14 positive, CD16 positive. Non-classical monocytes are CD14 low, CD16 high. So there's actually phenotypic differences on the different monocyte subpopulations. And it's absolutely critical because they all express different receptors, and they all have slightly different functions. For instance, classical monocytes actually have high levels of the ACE2 receptor, and intermediate monocytes and non-classical monocytes don't have any ACE2 receptors, so they can't be directly infected, but they are phagocytic. Okay, classical monocytes are not phagocytic. And this same thing came up in HIV back from my HIV days. You could not infect classical monocytes, CD14 positive, CD16 negative monocytes, because they didn't express CCR5. Okay.
Very interesting.
Intermediate monocytes were the ones that were indeed a long-lived population of HIV infection that in the beginning were refractory to most of the antiretrovirals. And then, of course, the non-classical monocytes express a little bit of CCR5, not a lot, but they express high levels of the fractalkine receptor. Okay, so it's so well developed in the literature, these subpopulations and what they do.
And so I was totally, as Alexander just said, I was actually traumatized that there are 6 doctors who sat down together, and then they said, Mobeen talked about non-classical monocyte. That's the wrong thing. And I thought they could not even Google to go figure this out. Anyway, so I have 2 more questions for you.
Sure.
Number one, so understood that SARS-CoV-2 and there is spike protein and there is S1 and the virus is running around in the body. So monocyte has eaten that up at some point.
Yeah.
Number one, 2 questions. Number one, would you like to talk about if there is a concept of long vaccine or vaccine injury related to this mechanism? Mm-hmm. And number 2, if so, how does the monocyte end up with the spike protein from the vaccine? Vaccine spike protein is supposed to be within the muscle or maybe the local lymph node. Do they go there and pick it up, or does the S1 run around? Again, if this is a topic you want to discuss.
Yeah, of course, because, listen, billions and billions of doses of vaccine have been given out, and I think it was absolutely critical with the Alpha variant where people were dying left and right. Okay, we needed to do that. I don't have a position on that. I've been vaccinated all my life. I think in general they work fine. Again, I always had issues with the influenza vaccine because it was about 30% effective. That's neither here nor there. A lot of people got it, saved a lot of people. Um, so you can't possibly think that after billions of doses, there isn't some side effects in a very, very small percentage of people. Turns out a very, very small percentage of a billion people is a big number. So I do think we have data that S1 is being carried in their non-classical monocytes. We do have data that they have the same vascular inflammation markers that we find in long COVID. There are some differences. We see in long vax higher levels of interleukin 8 than we do in long COVID. So our algorithms have used that to separate the two. So yeah, there's some differences, but most importantly, there's a lot of similarities, which really leads us to believe that the S1 is sufficient to cause the underlying pathology, and you don't need replicating virus. I mean, everyone forgets one of the first papers we published was SARS-CoV-2 replication out to 87 days. I have I have no
I remember that.
I have no qualms about um, replication for weeks, but you can't convince me that 6 months or 9 months post infection, and we have data to show it, there just isn't full length viral virus because we do whole genome sequencing. So, like I said, I've been waiting forever for that article that says whole genome sequencing reveals full length alpha variant RNA in patient 3 years after infection. Haven't seen
I
it.
haven't seen that as well. I actually have been digging because there have been many folks who have reached out, patients and doctors and researchers, reached out to me to try to convince me that there are persistent viral reservoirs. And I can definitely be suspicious that there could be, but I have not seen that data yet
Right,
to say, okay, here is the proof that we
right.
have the reservoirs.
And it's going to require whole genome sequencing. But the fact of the matter is, there's a difference between persistence and replication competence. And I've said it so many times. Everyone talks persistence, persistence. Yeah, we published it first. We published that there was RNA persistence and S1 persistence in monocytes after sorting these cells and doing whole genome sequencing and then identifying the S1 protein by mass spec. Yeah, there is persistence, but persistence of fragments, or Jez Mesner used to call it debris, which I still love that term. Yeah, there is persistence of that. And when you do diagnostic techniques like ddPCR and in situ hybridization, they all look for small fragments. And you're going to find small fragments. I get it. But that you can't go from detecting a small fragment to saying I can make a new viral particle. Okay? And now it's shot because all these long COVID patients are getting reinfected and reinfected and reinfected. It would be impossible to say somebody has, replication competent virus from 3 years ago because, there's a great paper that came out, I think last summer, that said of 2,000 people who were infected by Omicron, 50% of them didn't know they were infected. Okay, so how do you then prove that it's an old infection instead of a new infection? You have to sequence it. So that's where it is, and like I said, we have more important things with our drug trials coming up. So
Got it. Got it.
that's what we're busy doing.
So I want to go to the management protocol as well, but what do you think if we can answer a few questions as well that would give the
Sure.
audience a little break to digest what they have heard so far? So let's start from, and audience cool beans, if you have a question, please put some cues with it so I can find it. So let's start from Faraz. Faraz says, please comment on bacteriophage theory of long COVID. And totally, you can pass on questions to say, hey, pass on this one. But
I
people
haven't heard someone talk about bacteriophage in 40 years. I started with bacteriophage, which of course are our bacterial viruses. But I haven't heard that theory. So.
Got it. Next question is Alexander. He's saying, is there an RCT to back up this treatment? So we
Yeah.
haven't talked about your treatment a lot other than you talking about it in the passing. I want to go do a deeper dive there as well. But do you have a comment on this question?
Well, you can actually show it, Dr. Bean, towards the end. We were going to address the RCT later, but we can pop it up now just so people don't have to wait. But here it is. It's in. So, we've gone to great pains to write this great adaptive protocol to test maraviroc and atorvastatin in long COVID, and we're really looking forward to getting started. And what we did is we spun out a new division of Incell DX, or Incell DX will probably be a division of Health Biotherapeutics, but Health Biotherapeutics has all of our drug patents and and a new team with deep pharmaceutical experience that will be taking this through the agency. So we're
Very
really
interesting.
excited about it. It's going to
So
be
when
about 300 patients, so 150 treatment, 150 placebo, and we're really looking forward to getting started on this.
Excellent. So very good question, Alexander, that brought us a view of this study. So when does it start? Is there any date yet?
So we're hoping to start, by the end of the year. I think we're well on our way. We have trial sites identified. We're doing all the paperwork for the trial sites. We've been raising money for the trial. So, like I said, we haven't taken a dime from, taxpayers to fund this trial. So, I think it's important to get it out and to get it to people in need.
Absolutely. So when you're ready with the study's results, or in the interim, its data or communication, I'll make the googly eyes monocytes with non-classical T-shirts on them.
Yeah.
So we have a
So,
question here. Sorry.
stellate ganglion blockade. You know what? In our patients, we now number close to 50,000 since we first began. We've treated about 18,000. Ganglion blockade, from what I've heard from patient experience, like a lot of the other kind of faddish things, is it works for a while, symptoms come back. And like I said, if indeed vascular inflammation is the underlying cause, you know what? You need to get rid of the cause. And from day one, we've treated the cause and not treated the symptoms. So that's where we stand on that.
So that actually brings me to a very important point that you actually said that a few minutes ago. When you manage or with your protocol, it seems like the patient can fully recover and stay recovered. Many protocols actually eventually have a relapse as well. So is this correct that they can
No, they
recover?
stay recovered until invariably they get reinfected. Or, occasionally they'll have another viral infection, which will temporarily give them symptom exacerbations. There seems to be a stereotypical symptom response on a patient by patient basis based on infections, but those typically go away. So yes, they stay treated. And then we have an acute COVID protocol. And now our www.covidlonghaulers.com is now accepting patients with acute COVID, where we manage that and mitigate some of the factors that may contribute to long COVID.
Got it. Thank you very much. And I am displaying this site. It is covidlonghaulers.com. Once again, I have no commercial interest. There are no monies that are changing hands. If this can be of somebody's use, more power to them. And thank you very much to Dr. Bruce and his
Thank you.
Patterson and his team for doing this. So John has a question. Do you still believe that strenuous exercise negates your treatment protocol? Did you have a belief like that before?
It's actually a great question. And, I was sent a book by an exercise immunologist from Australia about 6 months ago that I think we cited in our first paper on treatment. And, it absolutely supported what we're saying, and that exercise, even mental exercise, mobilizes the pro-inflammatory monocytes, the non-classical monocytes. So, what we do is it's all about pacing, and we have a watch and an app that's already on Apple and Android at www.itrackwellness.com. They'll be under the Health Biotherapeutics flagship shortly. But the bottom line is pacing. So we usually say no strenuous exercise the first 4 to 6 weeks. And we get that first repeat of the labs and that first or the second telemedicine visit so we can assess the symptoms. And if they're improving and the labs are normalizing, typically somewhere between 6 to 10 weeks, as soon as they start to normalize, we start increasing their exercise. And I've treated professional athletes. I've treated action movie stars who are in some blockbusters doing martial arts. I've treated, musicians, actors, actresses. And you know what? Every single one of them wants just what you want. And that is, I want to get back to doing what I used to do. That is the biggest, discussion on the first visit is how, I was a runner, or I was a triathlete, or I was a biker. And when can I get back to where I was? And the answer is you can. It's just going to take time. And 6 to 12 weeks is really, as we published in February, is really a good time frame. If someone has a lot of neuro symptoms, it could be a little bit longer. Children actually take shorter amounts of time because I think they have less comorbidities. And it's pretty dramatic when we treat kids. Both Maraviroc and atorvastatin have been shown to be safe in kids. And that's why we use that combination and not Prevastatin anymore. But anyway, it's really dramatic because they are sofa bound or bed bound. They can't go to school because they can't think. They can't do their after school sports. And when they get better and they're going back to school without accommodations, it's the whole reason I got into this. And you know what? I got a thank you note drawn on colored paper with colored pencils from a 12-year-old girl who said, "Thank you, Dr. Patterson, for making me better." And you know what? Whatever criticisms out there, whatever, I can handle that because that letter made all the difference in the world. I wouldn't change a thing. So that's who I'm fighting for.
Thank you. Thank you very much for this. Shadow Man says, I've had ME/CFS since 1993 after 6 bronchitis infections and then glandular fever and haven't been right since. We were the original group that was rubbished by doctors. Maybe help is on the way?
Oh, I would say so. I mean, I think we were the first to come out in the summer of 2020 and say, hey, you know what, something's going on. These acute patients that we had been following for 90 days, they still have massive inflammation. It's different than acute COVID and different pretty much in the levels of IL-6, which was pretty, predominant. And as you can see here, IL-6 doesn't come into play in our algorithm. And they were all gaslit by physicians and told that they had psychiatric problems. We were the first ones to recognize their suffering. And, ME/CFS, these patients have been suffering for decades, not just years or months. And I feel it. We've started to, you'll see ME/CFS is not on here because we're doing something special for ME/CFS because I think it's so heterogeneous. It could be Epstein-Barr, could be CMV, could be herpes. I was involved in the CMV work at Stanford on ME/CFS. It could be coronaviruses. It could be a number of different etiologies underlying it. They still have vascular inflammation. But the interesting thing with ME/CFS it's the only group of these chronic inflammatory conditions that doesn't have elevated CCL5 or RANTES. So there are some unique aspects of ME/CFS that are showing up in our algorithms, and so we're trying to model that separately because we want to see if ME/CFS separates into maybe three or four so far, 3 or 4 subclasses of ME/CFS. So ME/CFS is fascinating, and we are actively working. In fact, I just got data yesterday on our ME/CFS modeling. So yes, we are indeed working on that. But the long and short of it is ME/CFS patients also have vascular inflammation. So we're treating that in those patients with ME/CFS.
Got it. Thank you very much for this. DS has I think, a related question to this algo that is up on the screen already. DS says, is RANTES elevated in Lyme?
Absolutely. Almost more than long COVID. And the other thing about Lyme versus long COVID, SCD40L, the first protein produced in the thrombotic pathway, is 3 to 4 times that in long COVID. And like I said, very interesting, a long hauler index greater than 6 is almost universally chronic Lyme.
Got it. Thank you very much. One more question, and then we talk about the protocol, the management protocol. So this question is from Barb. What are the tests to detect rogue spike proteins still being generated? Where is the documentation to take to our doctors? Thank you.
Yeah, I wish I brought a test report, but we've launched the S1 test, at least the S1 that's been phagocytized by monocytes and found in both intermediate and non-classical monocytes. That's been commercialized already. So again, you go to the covidlonghaulers.com website, and we can do S1 testing and follow that over time to make sure that by blocking fractalkine, this is actually a great slide. This is the report for the cytokines.
Okay.
But with the spike protein, we make sure that that's gone by the time we start taking patients off therapy.
Got it. So there are still a bunch of questions. I'll go to them later on. I want to hear, how is your protocol? How did it evolve to have statins with it as well? And how is it doing?
I think we started it when we found the evidence of vascular inflammation and started to think about what we could do to block this pathway. The other thing that was important to us, and also came out in this NIH paper, is long COVID is a massive monocyte macrophage disease. And from the cancer literature, the CCR5 antagonists repolarize monocytes macrophages away from a pro-inflammatory phenotype. The other thing we found in long COVID was elevated VEGF almost across the board. Maraviroc is in the literature as reducing levels of VEGF. So those are two very important aspects of using Maraviroc, is reduction of IL-16F alpha, interleukin 8, VEGF, SCD40L, through pathways that either have been published or we found in that initial paper. Then the second thing was to include the statin. We found some patients taking Maraviroc, it makes them feel great, but we need that statin to reduce fractalkine and binding of these non-classical monocytes to the endothelium. And that's been very effective. And, that's all kind of borne out in these slides. So that's where we started. And that's the basis for our clinical trial, is a combination of Maraviroc and atorvastatin. Atorvastatin is a little bit more potent anti-inflammatory than pravastatin. So we chose to use that. And again, we're using statins at sub-cholesterol lowering doses. so that we don't run into all the things that people talk about in terms of statin side effects. And this regimen has been very, very well tolerated, and absent significant side effects. And of 18,000 patients take Maraviroc, we haven't had to stop Maraviroc in a single patient because of a liver enzyme elevation. So I think a lot of that was, was just just fear from the warnings on the label. But if you look at the bottle of Tylenol, it looks very much the same.
Got it. Got it. So thank you very much for this. Maraviroc and the atorvastatin.
The other thing to
Do
mention
the
with
doctors so
Maraviroc, I think it was about 3 months ago, was shown to have positive neurocognitive effects and bring back memory in Alzheimer's. And I got all these phone calls saying, "Hey, Patterson, you're not so crazy about using, Maraviroc in long COVID," because, the thought being that microglia are responsible for making the tau protein. Okay, so you repolarize the monocyte macrophage lineage of cells away from this pro-inflammatory phenotype. Just has positive effects everywhere, including positive neurocognitive effects. So I think that's a great side note for the use of Maraviroc.
got it. Thank you very much. So we talked about the long COVID. We talked about the protocol for diagnosing. Then we talked about the diagnostic kit that your organization has and the management approach. Are you comfortable? Some more questions? I know it is going to be, is it too late on
Oh,
your
no,
side? It's about an
no,
hour.
I get excited about the questions. So we
Okay,
can get to
excellent.
answer them in person.
Excellent. So some more questions. Faraz says, IgG4 as a blood work marker, is it pertinent in diagnosing?
No, not for us.
Perfect. And someone made this comment. So Patty said, Dr. Bean, could you translate? So what I'll have to do is, Dr. Patterson, I'll have to do a follow-up talk to explain all these
Yeah.
biomarkers and the fractal keens in with the drawings and the cartoons. So Patty, I'll do follow-up, further
Dr.
explain.
Bean, even my family asked for your drawings so they could understand what I'm talking about at dinner.
Yeah, so I'm gonna have to draw some of these to kind of support your talk. So Patty, look forward to that. Hopefully in the coming weeks. Art says no blood-brain hindrances, and I had this question as well. That all of this, the monocytes and carrying S1, vascular inflammation. Have you had any observation for the blood-brain barrier, and if there is any
Yeah.
problems there?
No, I mean, these cells get through the blood-brain barrier for sure. And the good news is both Maraviroc and atorvastatin get through the blood-brain barrier. So obviously, the brain and the positive neurocognitive effects of Maraviroc are absolutely critical, because we've seen, again, patients with long COVID commonly have anxiety and depression. And the bottom line is you relieve the inflammation and those get better. I feel for the long COVID patients who get mental health issues, A, from being chronically ill for so long, but B, it may be part and parcel to the disease process itself. And so we spend the better part of our days thinking about what's going on in the brain. Obviously, the data coming out on Maraviroc in dementia and other neurodegenerative disorders is absolutely critical. And we're really excited about that, because we can get what we need to get in terms of therapeutics across the blood-brain barrier and negate the inflammation that takes place there.
Absolutely, that is amazing. Somehow my network became interrupted for a second. So one cave scout says, Moraviroc is about $500 a month, not cheap. So how do patients? I mean,
Yeah, so we have really good news. I mean, I think, and it was fair early on when we were developing all this stuff. The telemedicine visits, the diagnostics, the drugs, were not cheap. Um, the good news is with our RCT and our clinical trial, we're already working on reimbursement for the drug. So, and the drug combination, we're going to make a single pill that has both Maraviroc and the statin in them. Take twice a day, ultimately. And again, when that becomes reimbursed, it should be nominal. The best news just last week is that our cytokine panel is being reimbursed, and especially through Medicare for the cytokines. That's very exciting because, like I said, we don't want to exclude people because of cost. And I think that was an early criticism of what we were doing, and it was probably fair. But we had no other way to do it. If it works, it works. And, it's hard to say, well, you know what? We're really confident it works. Our process works because we're not relying on subjective symptoms to monitor your progress. So we have, a blood test to say, A, you have long COVID, and B, you're responding to therapy. And then, of course, the drugs aren't cheap. So all of that we've been working on for the better part of the last 2 years. And I appreciate that comment because it's not false. The only thing I'll say is it was $1,800 a month. And you know what we found out is there is a resurgence of Maraviroc use, probably because of the protocol that we developed. And so the price has actually gone down because of volume. At least that's what we've heard from talking to some really big pharmacies.
got it. Thank you very much. And another related question, which skipped by, I cannot find it. But the question, if I can paraphrase, was something like, "How do I find a doctor who can manage?" So, is this the long COVID long haulers? Is this a site to go to find help?
Yes, it is. And we're very excited because we're going to expand the COVIDlonghaulers.com. Not only are we going to be a consulting service and data analytics service, as we always have been, but I would say by the end of the year, we're going to start to offer full service. So we'll be able to, diagnose, do telemedicine, and prescribe. And I think that'll get around some of the roadblocks where you had to get your PCP to write prescriptions that we would recommend based on, interpretation of the diagnostics. And so I think that's going to be another key aspect of our program going forward, because you know how tough it's been to get PCPs, and then it's also been really hard to get PCPs kind of up to speed on what we're doing and why we're doing it.
Got it. Thank you very much. So for the audience, covidlonghaulers.com.
Correct.
And once again, I keep giving this disclaimer, no
Please do.
commissions here, no financial strings attached here. Okay, so the next question. Carson's channel says, what is causing blurry vision and anosmia in long COVID and how to fix it?
Inflammation. I mean, there's a great paper that showed, of course, activated macrophages surrounding the vagus nerve, when they're investigating dysautonomia. And the same can be true of all the muscles that control your eyes and your vision and being able to focus. I've also had a lot of patients who have what's called floaters, which I think is nothing more than a vitreous detachment, not a retinal detachment, which is severe and requires immediate care, but a vitreous detachment, which is basically the gel in the eye. And then you get floaters, and it's all because obviously the eye is highly, highly vascular. And so that's what's going with the blurry vision. And the same thing with smell, is I suspect that, the nerves controlling smell are surrounded by inflammatory cells, and it's just going to take time for those to go away.
Actually, You're very correct. There was a study that I had presented about 2 years ago where they said that for anosmia, the olfactory nerves, little neurons that are dangling on the roof of our nose,
Yeah,
the epithelium around that, which I would consider has the immune cells in it, that epithelium becomes inflamed and it
mhm,
presses on the olfactory nerve and causes it to start
yeah,
becoming, malfunctioning. So very
exactly.
interesting.
Yeah, exactly. So, I mean, it's amazing the breadth of the symptoms that go away when you relieve the chronic inflammation of long COVID.
Very
So,
interesting. Thank you very much. Eric says, any ideas on the half-life of S1 protein after taking Miraviroc? How does the body detoxify S1?
when it becomes phagocytized by monocytes, we can get rid of the monocytes using our protocol. And we can actually follow, because we have this quantitative assay called immunoquant S1, and we can follow the percentage of cells carrying S1 over time. And it really fits within our 6 to 12 week window of getting rid of monocytes carrying the S1 protein.
So just I am visualizing because I'll have to do a lecture afterwards because check this out. Alexander is also saying more drawings. So is this that when we are using Miraviroc and statins, then the attachment of the monocyte to the blood vessel is not occurring, it is hindered. And now
Correct.
those free floating monocytes will have to die within 5-6 days.
We do.
And that is how we kick them out.
Their apoptotic program comes back on.
Okay, I will do a lecture on that. Thank you very much. Um, then Faraz says, thank you, Dr. Patterson. You are a hero. Uh, there is another thanks. Let me just quickly see if there are more questions. There is a question here. Dr. Iron Mom says, are these labs I can order for my patients from most labs? Will insurance cover them? If so, what codes will I need?
So, as a physician and physicians group, they can be ordered through the website, covidlonghaulers.com. Kits are sent to the doctor's offices or to the patients. And like I said, we are now getting pretty broad insurance coverage. So that's all good news. And there's actually, you'll get a order form or a requisition that comes in the kits that are sent to either your office or to the patients. So all of that is in the kit, and so the kits are sent all over the United States from a centralized our centralized kit repository.
So, for a physician, if they wanted to order this, do they go to this site, covidlonghaulers.com, and then they go to for physicians and fill this
Well,
out?
or better yet, for a physicians group, go to customer service at incelldx.com, and then we'll set up an account, and we could actually send stocking kits to the offices, the physicians' offices. We do a lot of that right now.
Okay. So, this is the Incel DX, and probably you go to contact us, and over here,
It's
there will be a
actually
way.
it's actually customer service at incelldx.com.
Okay.
Yeah,
So, customer service at. So
yeah,
that is the email address.
that's an email address. Yeah.
Okay, got it. Got it. Thank you. When I am presenting, I become a little absent-minded other than what I'm talking about.
You're
So,
amazing.
Dr.
I mean, being able to do all this stuff. I mean, I have problems
Thank
with
you.
Zoom. I have problems with Zoom calls.
You are doing the research that we all need. So, Dr. Iron Mom, thank you very much. That was a good question. Faraz says, fascinated by AI in the research, please include in your debrief lectures. Thanks in advance. It is a curious thing for me as well that how are you using AI? Is it something like ChatGPT or is it your own
No,
internal model?
it's our own modeling. In fact, in our new paper, which is a recast of what's called a cytokine hub paper, which has the differentiation between long COVID, Lyme, acute COVID, and healthy controls. We go through all the derivation of machine learning and optimization of the different models, whether it's decision tree or light GBM, or I mean things that we have a great group working on that. Our IT group's amazing, and they even created our own proprietary portal where we save all this data on 50,000 patients so that we can keep asking the data in a blinded way, keep asking the data a question. I mean, do you want to know,
I love it.
are there more women with long COVID than men? Yes. What's the age group? It's bimodal. It's how many kids have it. I mean, the bottom line is we're trying to get this out as quickly as possible and get the drug approved as quickly as possible. We write papers as fast as we possibly can and still have to wait 8 to 12 months. I mean, for it to come out in press, it just can't happen fast enough for us. But we're going to continue to write and get it out in preprint servers and do what we can. But we don't have that kind of time, because we're trying to actually make a difference.
And if I can add a little plug from me as well, if you go to DrBeen.com, we are actually working on the AI as well. And right now, our team is busy creating a model of Dr. Bean's all the videos transcripts. So you can actually go here to Dr. Bean's dashboard and you can ask questions about various lectures to say, did Dr. Mobeen talk about, let's say, Moravirog? And if he did, where did he talk about it, or what was the discussion? So there is some AI at Dr. Bean as well that is happening. It is
Fantastic.
pretty exciting.
Bravo.
We are training our own model.
That's great.
So Nipa says, what about using ashwagandha, ginkgo, and brahmi?
If it works, it works. I mean, I'm pretty neutral on supplements. I'm all about nutritional and mitochondrial support. I don't think that's a major underlying mechanism. I do think it's important as these patients recover. The number one goal is to get rid of the inflammation and to get the blood vessels in good shape. And if they get acute COVID, protect the blood vessels. That's why we have a new protocol for acute COVID to do that. So, but as far as supplements,
to this
I'm not
beautiful question.
Yeah. So www.covidlonghaulers.com. We take care of acute COVID. I always tell my long COVID patients, your first call should be to your loved one. Your second call should be to us. So we can, the two goals of treating acute COVID are minimize the viral load, protect the blood vessels. So we've used the protocol in probably 300 to 400 patients. We haven't yet to have one that has gone on to long COVID. So I think minimizing the viral load, because like I said, that S1 was in monocytes in acute COVID, late in acute COVID when it was severe. Minimize viral load, protect the blood vessels. That's my philosophy.
Thank you very much. I am just looking here because I'm going through the questions. So there's a question from Rock Tech. Does quantum NSC work with this protocol?
You know what? Again, you can take it with our protocol. It doesn't, it's neither here nor there. We used NAC 2 years ago, and because we have a tool to say, what is that doing to the inflammation? We found that NAC wasn't doing all that much to inflammation. The other drug that's commonly used, LDN, it may be great, for sleep, but we didn't find it budged any of the cytokines when we used it alone way back. So, but like I said, all of those are compatible with our protocol. So, we'll figure it out. And like I said, if there's an opportunity with active line, we'll do doxycycline, Moravirog, and torvastatin. If it's ME/CFS, we'll do we'll do Valtrex, Moravirog, atorvastatin. So.
Thank you. Gold Country Russ says, is there something we should do for our daughter who has been treated for POTS for many years? Not a lot of progress so far. Maybe it's a tick-borne virus.
Absolutely no, or a tick-borne organism,
Yeah,
Borrelia, Bartonella, Babesia, Rickettsia, Anaplasma. I mean, there's so much out there that I mean, POTS literally is because the blood vessels are inflamed and they can't regulate either pressure and pressure. Blood pressure is intimately related to heart rate. And so, to me, everyone goes it has a diagnosis of POTS. POTS is a symptom. It's not a underlying, condition. So,
got it. Thank you very much. There are so many questions that it almost seems like I need to have you once more to continue talk about the questions. So I'll ask a few more, and if there are more, we'll
I'm
request you
I'm
and
I'm
have your
I'm
time.
happy to answer them. We could have a fireside chat and just answer questions.
Awesome. So London Lorraine says burning neuropathy post Miravirog treatment, elevated VEGF and SCD40L. Any suggestions?
Keep going. I mean, Maravirac's the only drug I know that brings down VEGF and SCD40L, and it's the neuropathy is not from the Maravirac; it's from the VEGF. So that's a
Got it.
common effect of VEGF is peripheral neuropathy.
Thank you. Faraz says urolithin A anti-inflammatory. Is it helpful in long COVID?
I have no idea.
Barb says I've had floaters for a long time, no due to not due to retinal effects. I have uveitis. Eye floaters are considered parasite related to some parasite medicine
Hmm.
journals.
They could be, especially if they cause vasculitis
Hmm.
in the eye.
Hmm.
Yep.
How do we manage the inflammation in our body to control it since that is what is harming us?
See, it's a catch-22, and I don't know if I mentioned this, but after the influenza pandemic in 1918, there was a surge in atherosclerosis and cardiac disease. It was almost unheard of pre-pandemic. So that's what started me over the last 3 or 4 months to start really attacking and trying to partner on with cardiovascular companies because I do think relieving this vascular inflammation is an absolute paramount to good heart health and not having any further complications from COVID or any other viral infection for that matter. Um, Managing inflammation, I think, is absolutely critical. Having a test that you can say there is inflammation is also important because you know there's almost 20 to 30 million Americans with long COVID. There's probably 5 to 10 million with Lyme who don't even, and many of them who don't even know it. It's underreported like crazy. ME/CFS, of course, is a massive healthcare concern. Chronic inflammation is the biggest healthcare issue worldwide. Something like 1 in 4 people in the world have some chronic inflammatory condition. So
So,
solving that puzzle, which may be at the heart of many, many things. So we're now trying to figure out this new mechanism that we coined uh, monocyte mediated um, uh, post infectious um, pathogens. And so we're now thinking that these may mediate chronic inflammation. Could be at the heart of autoimmunity. We don't know, but it certainly would be the first place I would look is to sort these cells and to get more into proteomics and see if they are carrying something foreign proteins and present them to the immune system. And we don't know they're there because we're not screening for them. So I think one of the best things we've done is with this diagnostic test coming out for long COVID is now we've identified so many patients with tick-borne disease and ME/CFS, and so it's been really gratifying because of that.
excellent. Thank you very much. In the US, more than 50% of the population has some disease attributable to chronic inflammatory state. And
Hmm.
in certain age groups, even 64% of the population of the US has such diseases. So thank you. Um, Astrovulix says, does this treatment help with post-vaccine small fiber neuropathy?
Yeah, we've been treating it. So covidlonghaulers.com. We will change, the website name at some point because we are treating everything from,
Hmm,
long vax to, Lyme to ME/CFS.
got it. Thank you. MGW says, is this protocol required forever or does it remove all the issues after a course?
Nope, 6 to 12 weeks plus or minus. So not forever. Although I've had some patients who feel so good on the regimen, they don't want to go off. And so it's kind of funny in that way. But
They must have a lot of
we take,
money as well.
so we take them off and, let them
Yeah.
go on their way.
Guy Telfer says macrophage apoptosis. So I think you made a comment about apoptosis. So this may be related to that
Monocytes.
apoptosis.
Yeah. So
Kingpin says, can someone recover from this disease naturally without this protocol?
I
Fasting
think there was
supplements.
a paper published about that in long COVID, and I don't think that percentage is very high of people who recover on their own. I mean, look at chronic Lyme. I mean, there's some patients that are decades out, and I think it's a similar mechanism. So we have to address that.
Makes sense. Paul says, could you please tell us if medical insurance covers these costs Dr. Bruce Patterson is talking about?
Yes, I can finally say that. So again, every plan is different. The percentages are different, but we are getting a lot of the costs covered. And the price of Maraviroc has come way down from when we first started using it to $1,800 a month to more around $500 a month.
So I think some of the questions are now repeating because the cool beans may have been joining us late.
Yeah.
So some of these questions are answered before as well. And if you rewatch, for example, this next question you've also addressed before, RJ Production says, is there a specific test for long COVID yet? How do we know for sure that this is long COVID and not something else?
The answer is yes, and we've shown it. It's right here. I'm tired of people saying there's no test for long COVID because if you look at these pies, they're distinct. In blue is long COVID, yellow is non-perturbed or healthy controls in acute COVID, and green is Lyme. There is a test for long COVID, and it's coming out in our new cytokine hub paper. The statistics, not only of detecting long COVID, which we can do with 96% sensitivity, 98% specificity, most importantly, a 98% negative predictive value. But we also are able to differentiate that from Lyme and acute COVID.
Thank you very much. Let me just see. Let's do two more questions. John says, how does mast cell activation affect these treatment strategies?
You know what? Mast cell activation, I don't see, at least in the patients I see from around the world, I don't think it's a major contributor to long COVID. I mean, I've had so many people taking Zyrtec and famotidine, and it does nothing. So I don't think mast cell activation is a big deal. I don't really think microclots are that big of a deal because the anticoagulants have not worked. And as some other scientists I was talking to mentioned from the laboratory world, if you send blood through microfluidics, or even if you use a pipette tip that is too small, when you're pipetting it into whatever acid, it'll cause microclots. So, and I've seen pictures of them, and frankly, I think some of the microclots look like epithelial mesenchymal transition cells. I did a lot of work on CTCs and cancer, saw a lot of different things in blood, which we stained with antibodies, etc. And these big rectangular cells look exactly like an epithelial cell combines with a monocyte macrophage from tissue damage and appears in blood, and it lights up with every antibody because it's hard to block antibody binding to macrophages. I just don't think microclots are a big deal. Of course, we tried Plavix for a long time, and it really didn't change the course in our long COVID patients. So,
I was going to ask that. Sorry, please complete your thought. My apologies.
so no, I think mast cell activation, I don't think much of, and I don't think microclots are that big of a deal, if they even exist.
So that's what I was going to ask. So this is my question. So bonus question, and that is that there are many physicians who are treating long COVID with a lot of blood thinners. Is that, I think, even if there are microclots and they're using it with some success, would that still not take care of the basic pathology, and that pathology is
Right.
still there?
I know
How do you see that?
and frankly, it scares me. I mean, some of these anticoagulants are very powerful and can lead to bleeding. And so, uh, like I said, we've tried anticoagulants with our protocol, mostly Plavix, but it really hasn't changed the course in our cohort.
Last questions. Look, there are. I think we'll have to request you to come back. So, Cool Beans, if you would like Dr. Bruce Patterson to come back and answer more questions, please type so, and I would reach out again. Last question. Mark says, "What is the cause of foot pain? I've been showing signs of MS ever since getting long COVID."
Well, I think that's a great question because there's some there's two answers I'd like to show. I mean, one is the foot pain is probably because of high VEGF. VEGF causes peripheral neuropathy. I've had plenty of patients with foot pain. Maraviroc brings down VEGF, and the foot pain usually gets better. Takes a while, but it gets better. As far as MS is concerned, I am very cautious of any autoantibody test in somebody who has chronic inflammation. From a laboratory perspective, where I've spent 25 years of my life, if you have chronic inflammation, things stick like crazy. So you're doing these assays in a plastic plate, and you're looking for autoantibodies. And antibodies can stick, and different fluorescent stains can stick if somebody's inflamed. So the false positivity rate is very high. So I'm very cautious interpreting ANAs for autoantibodies in long COVID. I think autoantibodies in long COVID was a theory a while ago in the beginning. I think that's been debunked for the most part. There are some conditions like PANS pandas, which I treat a lot of those kids, where there is both a neuro-directed autoantibody component and a chronic inflammatory component. And we found IVIG, which removes autoantibodies, which MS would fall under an autoantibody condition. IVIG removes the autoantibodies, but they don't always get better. And I think it's really because they also have a chronic inflammatory component. And so, because it's post-infectious. And so I think it's important to look at autoantibodies when you've relieved the chronic inflammation and you're not inflamed, because I think you're going to get a high rate of false positives.
Got it. And then just some, there are many questions, but I'm going to stop at this time. Just want to share some of the comments as well. This is an amazing interview, groundbreaking. Again, I'm just asking you questions. The work is all yours, and presentation is yours too. So thank you very much for what you and your team have been doing. Thank you very much for this. XYZ says, please enable captions. So about a couple of hours after this, the YouTube will process it, and then their AI would apply the captions. So maybe try them a little later. Look, yes, please, another interview. Yes, ask him to come back. So we already need you back.
Deal.
So with this, perfect.
Yeah, we'll come back. I think it's been a while. We've been quiet because we've been working so hard to get this trial designed and the algorithms built, and and basically, keep pushing the envelope forward that we started 3 years ago. when nobody was really talking about long COVID. Now everybody is. You know, we've been a little bit quiet just because we've been working so hard, but it's nice to be able to have a forum to come and speak about it. So we see all the things in the media, and we're not always cited on all the papers that are coming out because I think we published our stuff too long ago. Nevertheless, we're working for the patients and doing everything we can to lower costs, get therapies at work, all this stuff out to the market as quickly as possible.
Absolutely. So thank you very much for your work. You are welcome here anytime. Dr. Bean's channel has been on the cutting edge of this COVID era.
Absolutely.
So thank you for adding to
Absolutely.
the value of the content here and adding value to the patient's health.
Yeah, I appreciate it and look forward to the next time.
Perfect. Thank you very much. And Cool Beans, thank you very much as well. I'll see you tomorrow. Dr. Patterson, I'll see you hopefully in another few weeks.
Absolutely. Good night.
Thank you. Thank you. Good night.